Good evening, everybody. My name is Dr. Dennis Goodman, and I want to welcome you to our prevention series, the Heart Health Lecture Series, from the Center for Prevention of Cardiovascular Disease at NYU. I'll be introducing our fantastic speaker very shortly. Next slide. So, as you know, I'm a clinical professor in the Department of Medicine and Director of Integrative Medicine, and we have been running this series since 2015. And I always like to show tremendous gratitude to Anya Coates, who makes this all possible. So thank you, Anya. Next slide. So just some logistics you all know, and I'm so grateful to so many of you who stay loyal to the program, to our program. So you know that you can send it through the Q&A, a question during Dr. Hamo's talk. We have many questions already sent in, and I'll be fielding the live questions, and we'll get to as many as possible. Next slide. So this is how you keep in touch with us. There's the website, the email, and we're on Instagram and Twitter. Do get in touch with us because we have lots of information. And if there's anything you'd like to let us know about this lecture series or any specific topics that you'd like us to address, please let us know. The email is hearthealth@nyulangone.org. We have video library updates. Many of our talks have been recorded. You're able to go into the website, nyulangone.org/hearthealthlectures, or you can take a picture of this QR code. And on YouTube, many lectures are recorded, including the one today. So you'll be able to watch the lecture again or many of our previous talks that are in the archives. Next slide. These are the coming up lectures. On Tuesday, January 20th, we're going to talk about heart rate zones during exercise. So hot topic, and Dr. Sweeney is going to be answering the question, does it matter? Does it make a difference? And on Wednesday, the 4th, 2026, we're talking about women's hormones and heart health. And we're currently in the process of getting a speaker for March, hopefully on the topic of current management of diabetes. And that registration will be opening soon. Next slide. So today's topic is heart failure prevention made simple, what you need to know. It's a very important topic. There are almost 7 million people living in the United States with heart failure. I think the most important thing we can do is to try to prevent it. Dr. Hamo is a specialist in heart failure, and we are delighted that she has agreed to talk. I will just give you all a heads up. She's a real trooper. She's been sick with flu, and she's doing her best to give us this lecture tonight. So thank you so much for doing that, and get well soon. Chicken soup and tea and lemon and all that stuff. Please take it.
Thank you
As
very
well as
much.
vitamin C, zinc, and vitamin D. So Dr. Carine Hamo is currently an assistant professor in medicine and an advanced heart failure cardiologist at NYU Langone. She completed medical school at St. George's University and followed by her residency training at Stony Brook Hospital, where she also served as chief resident. She completed a fellowship in cardiovascular disease at Johns Hopkins University, during which time she earned a Master's of Health Science in Cardiovascular Epidemiology at the Bloomberg School of Public Health. She then continued her training in advanced heart failure and heart failure at Mount Sinai Hospital prior to joining NYU as faculty in 2022. Her clinical and research focus is on cardiometabolic disease in patients with heart failure, as well as heart failure prevention. So, I'm so happy to have you on. You're an absolute expert on heart failure. And I love that idea. And that's why we asked you that you're very focused, like we are in our center, on prevention, because that really is the best thing that we can try to do for everybody so that they don't have to be treated for heart failure, but you are, and your expertise is in heart failure. So I'm very grateful. Thank you, Dr. Hamo, for coming on. And we look forward to your talk.
Thank you so much, Dr. Goodman, for having me. Again, as Dr. Goodman mentioned, I do have a cold, so apologies if I pause for hydration. But I'm very excited to talk to you today about something that I am certainly very passionate about, which is heart failure prevention. So, our talk today will cover a few topics. First, I want to explain what heart failure is. We'll discuss why we should care about heart failure. What are the risk factors for heart failure? And importantly, how can we reduce heart failure risk? So, to start off, I want to explain what heart failure is. So, shown on the left is a picture of a normal heart. So, heart failure is a condition where the heart is essentially unable to meet the demands of the body. The main pumping chamber of the heart is the left ventricle, which you can see highlighted on the diagram on the left. And this chamber is really responsible for pumping blood out of the heart to the rest of the body. And in order to do that effectively, it needs to contract or squeeze to push blood out of the body, but it also needs to be able to relax to allow blood to enter the heart. So we traditionally think of heart failure as occurring due to one of two reasons. In half of the patients who have heart failure, the squeeze function of the heart is impaired. So it's not able to squeeze blood to the rest of the body. And this can happen if the walls of the heart muscle become thin, which can happen after a heart attack where the heart is not able to get enough blood supply. And this is termed heart failure with reduced ejection fraction. Ejection fraction is essentially the squeeze function of the heart. The other half of patients who have heart failure have a problem where perhaps the heart is stiff and it's not able to relax as well. And so the heart cannot fill with blood. And this can happen in patients who have long-standing hypertension or high blood pressure that causes the heart muscle to get thicker. This type of heart failure is termed heart failure with preserved ejection fraction. But the truth is that regardless of the cause of heart failure, the symptoms of heart failure are generally the same in everyone. And these primarily include shortness of breath, particularly with exertion, fatigue, chest pain, rapid heartbeat. Because the heart is not working as effectively, patients will have a tendency to build up fluid in the body. And this can manifest, again, as shortness of breath, but also swelling in the legs or ankles, swelling in the belly. And in more advanced stages of heart failure, because the heart is not able to get pump around the body to vital organs, some patients can begin to experience poor memory or cold hands and feet. So, how is heart failure diagnosed? Heart failure is a clinical diagnosis, meaning that there is not one specific test or laboratory abnormality that can be used to make the diagnosis. It's really diagnosed in a patient who has the signs and symptoms of heart failure, like the ones I mentioned, coupled with some structural abnormality of the heart, meaning that either the heart function is reduced, the heart walls are thick, or there's some valvular abnormality. And then patients should have one of the following: either an elevation in what's termed natriuretic peptides, which are proteins that can be measured in the blood. It's a protein that gets released from the heart anytime the heart is stretched, or some evidence of congestion in the form of fluid that can be seen on a chest x-ray. So now that we've reviewed what heart failure is and how it's diagnosed, why should we care about it? So Dr. Goodman mentioned that heart failure is increasingly common. The current estimate is that it impacts 6.7 million American adults over the age of 60 and about 60 million worldwide. Adults over the age of 18 and about 60 million worldwide. And these numbers are only projected to grow further, with an estimate up to 11.4 million by the year of 2050. Currently, it's estimated that 1 in 4 people will develop heart failure in their lifetime, which is quite staggering. Not only is heart failure increasingly common, but it's also a major killer, accounting for 45% of cardiovascular deaths in the US, Approximately 50% of people with heart failure will die within 5 years of the diagnosis. And heart failure is currently the #1 cause of hospitalization in the Medicare population. In the US, as of 2020, heart failure accounted for an estimated $32 billion in direct medical costs, and the total heart failure related costs are projected to increase even more. And really, the burden of the heart failure costs are related to the high rate in which these patients are hospitalized. So currently, we think about heart failure as occurring in 4 stages. So stage C is where patients have actual heart failure. And these are patients that have the signs and symptoms of heart failure that I mentioned and receive a diagnosis. Once individuals are diagnosed with heart failure, they are followed by a cardiologist or a heart failure specialist like myself and are started on medications to try and help them feel better and reduce the burden of disease. If heart failure progressed further, and sometimes this can happen, patients enter stage D, where they have more advanced disease, and then they may not be as responsive to medical therapy. And then we have to think about more advanced therapies like a heart transplant. But I want to focus the remainder of the talk on stage A and stage B. So stage A are individuals who are at risk for heart failure, but who don't currently have signs or symptoms or structural abnormalities of the heart. So these are patients with risk factors such as hypertension, coronary artery disease, patients who have been exposed to cardiotoxic medications, or genetic abnormalities that are inherited. Stage B heart failure or pre-heart failure are patients who don't have signs or symptoms of heart failure, but have either evidence of structural heart disease or risk factors in addition to those abnormal blood tests that I mentioned earlier. So I don't want to talk too much about this, but just to sort of highlight that once patients are diagnosed with heart failure, there are a slew of medications that we try and get patients on. And these are different if they have heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. But we have really several medications that are not only beneficial in prolonging life, but also keeping patients out of the hospital and also helping them feel better. So what are the other real risk factors that we think about with heart failure? So the most common risk factors are the ones shown here, these traditional risk factors that perhaps you've all heard about. And these include high blood pressure, diabetes, obesity, coronary artery disease, and kidney disease. But there's also non-traditional risk factors that are important to keep in mind. Like I mentioned, exposure to certain cardiotoxic medications. So there are many chemotherapeutic agents that can have toxic impacts on the heart. There's psychological or mental health abnormalities. And there are also certain sex-specific risk factors that are unique to women, which I'll talk about on a subsequent slide. So this was a recent study that looked at really a broad range of the most common risk factors for heart failure in men and women to try and understand what's termed the population attributable fraction, or what proportion of that risk factor can be attributed to subsequent heart failure development. So this study found that hypertension was the leading risk factor for Black women and Black men, sorry. And obesity was the primary contributor of risk among white men and white women. And when they combined all of these risk factors together, so hypertension, diabetes, obesity, smoking, and hyperlipidemia, the combination of these 5 risk factors accounted for about 50% of heart failure cases. This was another recent study that came out where investigators looked at a broad range of risk factors for heart failure in women to determine the contribution that each of these risk factors made to heart failure development. And they found similarly that 46% of heart failure was attributed to these well-established traditional risk factors such as hypertension, diabetes, obesity, smoking. Another quarter of heart failure was attributed to previously under-recognized risk factors that disproportionately affect women compared to men. And these include depressive and anxiety symptoms, neuroticism, high deprivation, low socioeconomic status. And then about 16% were due to female-specific factors, such as reproductive factors, including early age at menopause, gestational diabetes or gestational hypertension, chronic inflammatory conditions, high parity. Sorry about that. So, and we're now understanding more and more that there are certain risk factors like obesity, insulin resistance, metabolic syndrome that are very much interrelated. And you likely may know that we have a growing rise of obesity and diabetes in the United States. And these really are the primary drivers of not only cardiovascular disease, but also heart failure risk. And all of these conditions, we're now understanding that they all are very much interrelated, and these, organ systems talk to each other. So kidney disease, metabolic conditions like insulin resistance, diabetes, obesity, and cardiovascular disease are all highly interrelated. And in recognition of this, the American Heart Association recently coined the term cardiovascular kidney metabolic syndrome. And a study found that almost 90% of US adults actually meet the criteria for CKM based on the presence of these risk factors. So this is the current staging system for CKM, or cardiovascular kidney metabolic syndrome, whereby individuals in stage 1 might have excess adiposity, maybe overweight, have impaired glucose tolerance. Individuals in stage 2 then progress to overt hypertension or elevated triglycerides, metabolic syndrome, diabetes. And then once you reach stage 3, you have evidence of what we call subclinical cardiovascular disease, where you may have coronary calcifications in the arteries of your heart, or you may have some abnormalities on an echocardiogram, but you don't have overt disease until you progress into stage 4, where individuals have hello? Oh, sorry, my screen just went blank. Are you all able to hear me?
Yes.
Okay, sorry about that. Let me just go back. Sorry.
No problem.
Okay. Then you progress into stage 4, where individuals will develop overt cardiovascular disease like peripheral arterial disease, heart failure, stroke. And really the rationale behind coining this term or construct is really to try and identify people early on in the spectrum, to try and target these risk factors and reduce the progression to the later stages where they actually have cardiovascular disease. And the overlap of these cardiometabolic conditions and heart failure is really supported by a shared pathophysiology or mechanisms that overlap. And these include inflammation, oxidative stress, adiposity, insulin resistance, endothelial dysfunction. All of these pathways and mechanisms are abnormal in patients with these cardiometabolic risk factors such as hypertension, obesity, diabetes, but they're also playing an important role in the development of heart failure. Now, a lot of my research focuses on these cardiometabolic risk factors, obesity, diabetes, and hypertension. And we know that in an ideal world, people wouldn't have these risk factors at all. But that's oftentimes not necessarily practical or realistic. And so, what I was interested in understanding is, well, what if we look at different degrees of control of these risk factors? So, for example, if we look at blood pressure in individuals with hypertension or the hemoglobin A1C in individuals with diabetes, and we categorize them based on the severity of these risk factors. How does the severity and the number of risk factors change the risk for developing heart failure down the line? And we found that in individuals who had 2 or 3 severely uncontrolled risk factors, and this we defined as diabetes with the hemoglobin A1C greater than or equal to 8, hypertension with a systolic blood pressure greater than or equal to 160, and obesity with a BMI greater than or equal to 35, these individuals had a 3-fold higher risk of developing heart failure. So really a prime population. Oh, sorry about that. A prime population to try and target, even if we cannot, even if we can't prevent these risk factors altogether, at least preventing the severity of these risk factors. So, what are some tools that we have to try and identify what individuals are most at risk? So, the American Heart Association about 2 years ago came out with a risk score called the Prevent Risk Calculator. And this risk calculator can make an estimate for an individual's 10 and 30-year risk of developing heart failure. And you can see here the different metrics or parameters that are included in the calculator. So, things that you might expect, a lot of the risk factors that we've already talked about, age, cholesterol, body mass index, blood pressure, diabetes, kidney function. But this score also includes some of these metrics that are now highlighted by this cardiovascular kidney metabolic syndrome construct, such as looking at urine albumin creatinine or how much protein is gets excreted from the kidneys, the hemoglobin A1C, as well as a social deprivation index using your zip codes. So this is just an example that I put together, to sort of demonstrate what an individual's risk might be. So a 55-year-old female with a history of diabetes and hypertension, she has a total cholesterol of 200, an HDL of 60, a body mass index of 35, and she's a non-smoker. And so the Prevent risk score would estimate her 10-year risk of heart failure being at 11.2%. And you can sort of, go online and certainly calculate this for yourself, but also even have a conversation with your primary care doctor or your cardiologist about this to try and understand what are the different metrics that are might contribute more to your risk of not only cardiovascular disease but heart failure specifically. So we're still learning more about the best ways to use the risk calculator, and how it can sort of help guide discussions. But one sort of algorithm proposes that you can, calculate the 10-year heart failure risk, and then based on sort of where you fall, and maybe, having a discussion with your cardiologist about what other risk factors you have that are specific to you, such as we talked about rheumatologic conditions or disorders that, occurred during pregnancy, like diabetes and hypertension. And that can sort of guide your strategy for risk factor reduction, either through lifestyle modification or a combination of lifestyle modification and drug therapy. And then if there's an uncertainty, you can talk with your doctor about maybe using some of the lab tests that we mentioned or imaging such as an echocardiogram to help guide the decision further. So currently, this is our approach to heart failure prevention, which is that in everyone, we want to promote healthy lifestyle behaviors, and we want to focus on metabolic health, blood pressure control, reducing the kidney disease or the progression of kidney disease. And then in individuals with atherosclerotic heart disease, we want to make sure that we're preventing further complications from that, with the mainstay therapy being statins. So this is our current approach to heart failure prevention in terms of lifestyle and risk behaviors. This was put forth by the American Heart Association to sort of highlight the 8 most important risk factors for heart failure. And these are the key, or cardiovascular disease in general. And these include healthy eating, staying active, making sure you get enough sleep, of course, avoidance of smoking or smoking cessation, maintaining a healthy weight, and then controlling cholesterol, blood sugar, and blood pressure. So a healthy, balanced diet consists of fruits, vegetables, whole grains, lean proteins. It's important that we limit overly sweet drinks and sodas. And the American Heart Association actually has some wonderful resources, including, I put a link there to some recipes that are sort of focused on heart health that are really a great resource to go to if you're in need of healthy food ideas. And the most cardiovascular benefits have really been shown with 2 diets, primarily the Mediterranean and the DASH diets. This was a study that looked at 14 studies of different dietary patterns for the prevention of heart failure. And it showed that adhering to a Mediterranean diet and a DASH diet reduce the risk of heart failure development. This includes this. So the Mediterranean diet focuses on fruits, vegetables, plant-based eating, legumes, nuts, healthy fats like olive oil. They emphasize fish and poultry as the protein source, with limited amounts of red meat and low intake of processed foods or sugars. And the DASH diet was primarily developed for the management of hypertension. And this focuses on a diet that's low in salt, rich in fruits and vegetables, whole grains, low fat dairy, and lean protein. When it comes to exercise, the recommendation for adults 18 years or older is really to engage in 150 minutes of moderate intensity or 75 minutes of vigorous aerobic exercise each week, as well as strengthening exercises at least twice per week. And there's now growing recognition that sleep has important implications to cardiovascular health, with the recommendation really being for an average of 7 to 9 hours of sleep, which can sometimes be aspirational, but important to try and get as close to that as possible. And sleep also has an influence on other metrics of cardiovascular health, such as physical activity, weight, blood pressure. Poor sleep quality or inadequate duration of sleep can contribute to inflammation, cell injury, which increases the risk of coronary artery disease, hypertension, arrhythmias, in addition to metabolic syndrome. All of these are risk factors for heart failure, as we discussed. And then obstructive sleep apnea is sort of a separate entity, but it is a sleep-related disorder whereby breathing repeatedly starts and stops during sleep due to collapses of the upper airway. And sleep apnea, if not managed appropriately, can also result in the development of cardiovascular disease and heart failure specifically. So this I thought was interesting. Too much sleep can also be detrimental. So this was a study that was performed in South America that looked at the association between sleep time and the risk of all-cause death and 10-year cardiovascular risk. And it found that among patients with short sleep patterns, or less than 6 hours per night, but also prolonged sleep patterns, such as greater than 9 hours per night, had a higher risk of not only all-cause death, but cardiovascular risk. So, you really do want to try and be in that sweet spot of 6 to 9 or 7 to 9 hours per night. Just should be important to, of course, note that smoking cessation or smoking avoidance is incredibly important. And there are now so many different tools that are available to us to try and help our patients try and quit smoking. So this is definitely something to talk about with your providers. And in terms of drug therapy for heart failure prevention, so in the setting of high blood pressure, we know that more intensive blood pressure control was associated with a 37% lower risk of heart failure. We also know that treatment with medications in the class of SGLT2 inhibitors in individuals with diabetes was associated with a 35% lower risk of heart failure. And in terms of kidney protection, treatment with finerenone in individuals with kidney disease not only is associated with a reduced risk of kidney disease progression, but also a 32% lower risk of heart failure. So when should you seek medical help? So of course, if you have risk factors like high blood pressure, diabetes, or a family history of heart disease, if you notice the warning signs of heart failure that I mentioned, or, certainly sudden symptoms like chest pain, and also, regular checkups, of course, are best able to catch problems early and really try and target risk factors early on so that you don't run into a situation where you have developed heart disease. So the key takeaways that I'm hoping to leave you all with are that, most importantly, heart failure is preventable. Controlling risk factors like high blood pressure, obesity, and an avoidance of smoking are key to decreasing your risk. Eating a healthy diet, staying active, managing stress are very important, not only for cardiovascular disease risk reduction, but also for heart failure. And then seeking help early if you notice symptoms or have concerns. And I think really ongoing conversations with your providers about what your risk factors are and how you can best target them to reduce your risk are always very, very important. And with that, I'll open the floor to some questions.
Thank you so much, Dr. Hamo. That was fantastic. I couldn't help thinking that your talk is just so applicable, not only to heart failure prevention, but all the things that we worry about: heart attacks, strokes, dementia, inflammation in general, connective tissue disorders. I mean, there are just so many things that are preventable, so many diseases if you follow just the guidelines that you've given us. So that was really a brilliant, outstanding talk. Thank you so much. We've got a few questions that were sent in. So we'll go to the first one, Anya. Are there any differences in prevention strategies for men versus women?
Yeah, so this I highlighted somewhat. There are definitely certain risk factors for heart failure that are women's, or female specific. Diseases related to pregnancy, like I mentioned, hypertension, diabetes. I mentioned the chemotherapies or that can be cardiotoxic, but oftentimes those are chemotherapies that are used in the treatment of breast cancer. So that's also can be sort of female specific in that way. So, I think in terms of the risk factors, that's what really should guide the preventive approach. And so those can be different in men and women.
Thank you. Next question, Anya. What are the recommendations in the area of exercise, fluid intake, and diet for people with heart failure? I think you covered this, but maybe you could just elaborate a little bit about specifically things like fluid intake, and what about people who actually, have heart failure? There's a different, and then exercise becomes a different story.
Right. So we talked about the recommendations to prevent heart failure. Once you develop heart failure, things are a little bit different. So, in terms of fluid intake, a lot of times what patients with heart failure are struggling with are managing their fluid balance because they are more predisposed to building up water and fluid in their body. So, there is not necessarily a specific restriction. It's really just about instructing and guiding patients on being attuned to their body, weighing themselves daily, and making sure that they're not gaining weight every day that might suggest they're holding on to fluid. So sometimes, their fluid intake can sort of be modified in that setting. In terms of exercise, there's no clear sort of number of minutes. Certainly, the heart failure guidelines recommend that exercise and staying active is very important, even once you develop heart failure. So another sort of resource that we use all the time in patients with heart failure is cardiac rehab, where it's a structured exercise program and patients are, monitored and sort of with increased gradation of exercise over the course of the program. So that's something that we use a lot. And then the diet is also, very similar. Certainly, the Mediterranean diet would be beneficial in all individuals, regardless of whether or not they have heart disease or are just trying to prevent heart disease.
Yeah. Um, a question about high blood pressure. I'm just embarrassed to say that when I was training as a medical student in the 70s, we were taught that you could accept a blood pressure of 100 plus the person's age as a systolic. So if someone was 80, you would be accepted blood pressure of 170 up to 180. And the diastolic, obviously, we wanted that below 90. But I think that it's so important to realize, and you made this point, hypertension is one of the major causes for heart failure if it's untreated. So what do you recommend in terms of how aggressively are you recommending we treat blood pressure to try to to limit it as a risk factor?
Yeah, so in general, I try to target, around 130 over 80. Really above that, we know, and I showed you this in even some of my own work, that the higher the systolic blood pressure, the greater the risk for developing heart failure in the future. So, it's true that we used to be more lenient. Again, especially in the elderly, there were concerns over dropping the blood pressure too much, but we really know that over time, having high blood pressure not only increases your risk for heart failure, but for kidney disease, stroke, many other cardiovascular and vascular health conditions.
Absolutely. So we are pushing to try to get blood pressure exactly like you said, below 130 over 80. Sometimes we can't do that because people get symptoms like dizziness when we push the blood pressure pills. But we do our best to get people to, get the blood pressure low. And I want to make the point that a lot of times just by losing weight and exercising, that'll help you. Stress management, and I'm a believer in magnesium. I found that very helpful for helping to lower blood pressure when it's not that high. So I just wanted to throw that in. Next slide. When or what can heart failure patients do to safely increase or maintain ejection fraction? Exercise, supplements, diet, red light therapy, etc.
So we talked about sort of exercise. You mentioned some supplements. We talked about diet. Red light therapy, I'm not as familiar with in terms of, if there's, I don't know that there are established benefits in cardiovascular disease or heart failure specifically. So not something that I would necessarily recommend. I think surely there are always a lot of things that are still being developed and investigated and, and being studied in animals, for example, but unless it's really sort of prime time or established, I try not to recommend those types of therapies to patients.
Yeah, and I mean, red light therapy uses a low wavelength of red and near infrared light to stimulate cellular activity, and we haven't used it as a way to actually prevent heart failure. I think the main ways to do that are what you mentioned. Next question. Does peripheral artery disease increase risk of heart failure?
So the short answer to this is yes. And a lot of this, it goes back to sort of interrelated risk factors. So, diabetes, hypertension, coronary artery disease, all of these are not only very closely linked to the development of peripheral arterial disease, but also to the development of heart failure. So it's very hard to sort of tease one out from the other because they're all interrelated, and all these metabolic risk factors that might contribute to one contribute to the other as well.
Yeah. And part of peripheral artery disease is aortic aneurysms. And we know that in people who have peripheral artery disease, there's a high incidence of having coronary artery disease.
Right.
So a lot of times when we come across patients with PAD, peripheral arterial disease, and we screen them, we find they've got coronary disease as well. And people who've got peripheral artery disease in the legs, a lot of times they're limited in what they can do because they get claudication, pain in their legs. So they don't develop the symptoms of shortness of breath that you might otherwise get. So it's very important for patients with PAD to be screened, not just for disease in in the peripheral system, but also in the cardiovascular system, specifically the heart. Next slide. What if the heart failure was a consequence of a myocardial infarction, a heart attack? What could be done about that? And I think I made the point earlier, and you've made it. We really want to try to prevent people from having a heart attack. But if that is the cause of heart failure, we have multiple treatments, and maybe you could just mention it.
Yeah. So, right, regardless of the cause of heart failure, sometimes, despite our best efforts, or even, in the setting of a heart attack, patients will develop heart failure. And that's when we start to incorporate those medications that I mentioned on an earlier slide, where we have, many proven effective therapies to try not only to get the squeeze function of the heart more improved, but also to help patients feel better and do better in the long term.
Okay. Next slide. How can I get off blood pressure medication?
So this is, an interesting question. I can certainly understand, maybe not even blood pressure medication, but everyone and nobody likes to be on medication. So, certainly, I get asked this all the time in patients that are on medications. They're always hoping to limit the amount of pills that they need to take, or try and, if the numbers look better, they want to try and peel back the medications. But I think it's important to understand that, let's say, in this case, for example, if someone has hypertension and their blood pressure is better, that doesn't necessarily mean that it's okay to come off the blood pressure medication. The blood pressure is probably better controlled because of the blood pressure medication that they're taking. And, it certainly, I don't want to underestimate the burden of taking medications every day, but when we think about the long-term risk and complications that can happen from having uncontrolled high blood pressure, those are far greater. So, I think it all sort of depends on the circumstance. Something to talk about with your provider if you're having side effects or issues related to the blood pressure medication. But in general, if the blood pressure is well controlled on medication, I try and keep patients on it.
Definitely. I always tell patients their risk factors for high blood pressure, like too much salt or not exercising or being overweight. If we manage to control those things, we may be able to cut the blood pressure medication back, but we would do it very slowly and make sure your blood pressure doesn't go up. I did mention magnesium, and I have found that helpful, and people have already written in questions about magnesium. I'm a big fan of it. I think you've got to be very careful that you have normal renal function, but magnesium actually acts like a vasodilator, like a calcium channel blocker. So if it can be used, and in some patients, I've been able to cut back on the antihypertensive blood pressure pills by using magnesium. The dose of magnesium is about 300 milligrams per day in women and about 400 in men. And I'm not going to get into it now. We'll do it sometime. There are different types of magnesiums. I usually recommend one that ends in ATE, like glycinate or threonate or malate. If people are constipated, the citrate's a better form. So it's something that I think we'll do a talk about that. And we'll get into it. But I don't know how you feel about magnesium, but I think it's a very important mineral that isn't made by the body, and there are many benefits from having, a normal magnesium level.
Yeah.
So we've got a lot of compliments for you, and somebody wrote in and said it's great, they'd love the slides. And I think what I would just say to that is, this is recorded, and if you go to the YouTube presentation, you'll be able to see all these slides again. I don't know how you feel about the slides, but we generally just say you can see this presentation again and again, and see the slides and take any information that you want off them. I've got a question about MCAS. which I presume they mean mast cell activation syndrome. Does it play a role in coronary artery disease and heart failure? I mean, that's an abnormality of mast cells where you get histamine release and a lot of allergic symptoms. My understanding is that I'm not aware of it. Do you want to comment on that?
Yeah, I'm not as aware of it either. I don't know if there is too much evidence around. I mean, certainly, heart disease and heart failure in general is, a lot of it, a lot of the mechanisms are related to inflammation, but I don't know about MCAS specifically and whether there's been a demonstrated association with heart failure.
Okay. Lastly, someone asked about the heart diagram in the very beginning. You did a great job of showing, and they were concerned that there's such a vast difference between what a normal heart looks like and a heart with heart failure. And I think you could comment on that. And we've both seen that through medical school. The heart can become extremely enlarged when there's heart failure.
Yes. So of course there are, what I showed you was trying to sort of depict two extremes, and certainly patients with heart failure can fall anywhere in between. But, certainly in advanced heart failure, the heart does become more dilated and stretched out. So, that diagram that I showed you can definitely be seen, particularly in more advanced heart failure stages. But that is why we use the medications, and the medications are able to sort of work ideally to remodel the heart in a way that it, sort of you're attempting to at least regain that more normal configuration.
Thank you. Next slide, Anya. So I wanted to give you the information for getting access to any one of our physicians in the prevention center. There's the number for appointments. The website is below that, 212-263-4300. So Dr. Hamo is a cardiologist who's a specialist in heart failure, in treatment of heart failure. In terms of preventing heart failure, it was a fantastic talk. But if you'd like to have more information or talk to doctors that are focused particularly on prevention, then you would see one of our prevention specialists. If you want to see Dr. Hamo, if you or anybody you know wants to see a heart failure specialist, there is her phone number, or her office number, 646-501-0119. And there's the website for langone.org where you can get access to any of our specialists, their contact info. I want to say again, thank you so much for coming on, even though you're not feeling well. You gave a fantastic talk. It's as good as it gets. Clear slides, clear information. It was really wonderful, and we're very grateful. I want to wish everybody happy holidays. Be well, be safe, and remember prevention. No, nothing in excess, and that includes alcohol. So enjoy yourself if you can do it in moderation, and enjoy your family and be safe. So thank you very much, and thank you, Anya. And I look forward to seeing you all in the new year on January 20th for our next presentation. Thank you again, Carine.
Thank you.